speak about rheumatology and imaging, but as we have already spoken earlier, today we'll speak about rheumatology and imaging, but as we have already spoken earlier in conventional methods, today we'll talk about role of other than conventional radiology imaging methods in rheumatology. So what are the recent imaging modalities in rheumatology that we are adopting? One, of course, most popular and simpler is the ultrasonography, with or without color Doppler. Occasionally color Doppler may be used to know the increased vascularity to the lesion. Second, orthography. Today, conventional orthography is not done that much. Occasionally, where there is no MRI or other facilities, still the orthopedic surgeons and rheumatologists prefer orthography. Angiography, rarely we use after the color Doppler. MDCT, by MD means multi-detector CT, common. Radionuclide scan also is used for therapy in case of synovial thickening and granulomatous disorders. MRI and MR orthography. After the advent of MRI, the conventional orthography almost is not done anyway. Then recently PET CT scan and occasionally vascular and interventional radiological methods. For a man with a hammer in his hand, wanting to use it badly, everything in this world looks like a nail needing hammering. This I have said by Mark Twain. Why I said is, supposing you have got a facility of MRI, radionuclide scan, immediately you jump to, all right, pain in the shoulder, do MRI, forgetting about the simpler methods like conventional radiology or ultrasonography. Ultrasonography is simpler, as I said earlier, cheaper, making its impact in the initial diagnosis of arthritis even before conventional radiology. Sometimes if you are dedicated to ultrasonography and musculoskeletal system, you don't have to resort to usual conventional radiography where there is some risk of radiation exposure. Ultrasonography 2.25 to 10 megahertz. Difference in acoustic impedance, that is the principle. The difference in acoustic impedance in various tissues like bone, soft tissue, fluid, etc. For example, in this particular case, you look at the ultrasonography scan, an anechoic lesion is seen, which is Baker's cyst, the popliteal fossa. Now, in all the various types of arthritis, what are the advantages? Mostly we have got advantages only. Only disadvantage is that it is subjective. That means the doctor has to be with the patient in order to do that. Whereas in conventional radiography, CT, MRI, the imaging technologist or the radiographer can do and show the pictures monitored by the particular radiologist. Advantages: cheaper, simpler, and no radiation. Immediate information. As we are doing a fluoroscopy, you see virtual images. Same thing in ultrasonography. Immediately you can get the information particularly between cyst and solid. Often, even clinically, a cyst containing foam fluid, you cannot differentiate whether it is really solid or cyst. Effusions, immediately you can aspirate. Soft tissue and bone changes you can see. Tendon, ligament ruptures also easily you can diagnose, which by conventional radiology is not possible. And all muscular pathology also, muscular tears, muscular infiltrated by fat, metoma intramuscularly, all these things can be detected by ultrasonography. For example, in rheumatoid arthritis, look at these pictures, you could see the synovial thickening by the irregularity. Earlier I said acoustic impedance. So here we are talking about echoic areas, anechoic areas, hypoechoic areas, or mixed echoes. These are the terms that we use generally in ultrasonography. Same thing in your right hand side lower picture shows the erosion, early erosions, and a plain film of the hand, for example. Early erosions may not be seen unless 40% of the cortex is destroyed. Again, another case of osteoarthritis with Baker's cyst and loose bodies within. As I said, the principle is the cyst is anechoic or hypoechoic. Whereas the loose bodies, either chondral or osteochondral, they reflect, they are echoic. That's how you differentiate. There is a popliteal fossa Baker cyst, but there are loose bodies, multiple loose bodies. One on your left hand side, you see 30-year-old woman swelling in the left shoulder. That is the presentation to the rheumatologist. And then on the plain film, all you see is a soft tissue swelling around the head of the humerus, head and neck of the humerus. No bone erosions you can see, no lytic areas you can see, no calcifications you can see. Same thing down in a picture, again the lateral view of the humerus. Again you see the soft tissue swelling with no nondescript type of features. Whereas ultrasound on your right hand lower side, you could see multiple echogenic loose bodies, non-specific response to chronic synovial inflammation. These are called rice bodies, but these also can be seen in, say for example, tuberculosis also. Now in sports, today sports is very active part, all the young people and students are taking active part. So sometimes you find ruptures of ligaments as well as tendons. So this is an example, radiograph on your left hand side shows a soft tissue swelling in the region of the Achilles tendon. Of course, there is a calcaneal spur which is not very significant. And then you don't know there is a hematoma or a rupture, whereas in ultrasonography you could see the space and the hematoma and because of the rupture of the Achilles tendon. That is the advantage of ultrasonography. If it is chronic also, you can tell there is calcification, calcified hematoma. Now again, transverse scan, edematous tendoachilles with calcification. Look at the calcification echogenic area, the reflections you could see. And in this particular case, again there is retraction of the proximal end. You could nicely see by the arrows. And a hematoma. Hematoma, look at this. It is echogenic. That means it is a chronic hematoma. It is acute collection of hemorrhage or any fluid. It will be anechoic. Then sonography, power Doppler, color Doppler and power Doppler. For example, this carotid artery with various collagen vascular disorders, immunological disorders, you may find some changes in the vasculature. This is only an example of how a power Doppler shows the color flow, high sensitivity to the intraluminal flow. And then if there is obstruction, there are plaques, if there are ulcers, you can nicely see as reflecting. Now, in old days, even today, maybe rarely they do, who do contrastarthrography, because in plain films, you don't see the ligaments, bursa, and tendons. So in contrast, hydrogenated contrast you can use, water-soluble contrast you can use, and inject into the shoulder. And here you would identify the rotator cuff tear and the spill of the contrast into the subscapular bursa. And at times there is a frozen shoulder. Not much of contrast could be injected, limited space due to capsulitis and because of the adhesions. Here again, in the contrastarthrography, in the knee, patient is having a pain in the knee, particularly in the popliteal fossa. Often it is difficult to differentiate whether it is a ruptured Baker cyst or there is thrombophlebitis, the thrombosis of the calf veins. That is the major differential diagnosis in calf pain. So in that, you do a contrastarthrography and there is a rupture. There is a continuation of the synovial cavity into the Baker cyst. Look at the contrast. And instead of using single contrast with hydrogenated contrast, occasionally you can use air mixed with hydrogenated contrast. This is again just an example of Baker cyst, and also note the different adhesions in the suprapatellar fossa pouch. Again, synovial plicae in the air arthrogram, air contrast arthrogram, you can identify the landmarks of the bones, patella and suprapatellar pouch, and in the so-called synovial plicae, sometimes, not always, are significant and produce pain in the patients. And Hiparthrogram, particularly in children, where there is suspected congenital dysplasia of the acetabulum and hip with a dislocation, mild subluxation, you can use Hiparthrography to show the arthrogram and the limbus in the capsule. And angiography. When do you use angiography? Rarely we use in rheumatology, but then rheumatology comprises vasculitis, arthritis, osteoporosis, ligamentous tears, all these entities. So, for example, this is a periarthritis nodosa, an uncommon, not so common periarthritis nodosa, collagen vascular disorder. Note multiple microaneurysms of intrarenal arteries. See, nicely they are shown as a spherical densities. These are aneurysms, microaneurysms. You don't have to do a biopsy of an artery in order to diagnose periarthritis. And rarely also we use lymphangiogram to show the nodes. Even in rheumatological arthritis, etc., you can get not only synovial effusion, regional lymph nodes also may be enlarged, for example, Still's disease. So, where you can see the lymphatics as well as the lymph nodes, enlarged lymph nodes. And then most important is bones, measurement of bone mass, particularly where in case of osteoporosis. Is this osteoporosis, osteomalacia, or the degree of osteoporosis? Osteoporosis is a silent epidemic. So conventional, as I said earlier, 30 to 40% of the bone has to be depleted before you say there is osteopenia of the bones or osteoporosis of the bones. Single photon absorptiometry, dual X-ray absorptiometry, DXA, that is more or less popular today. Quantitative CT, not so popular. Quantitative US, not yet popular. Osteoporosis, as I have said already, is a progressive systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone rigidity and susceptibility to fractures even with minor trauma. As I said earlier, it is a silent epidemic. Porous and fragile bones, fracture, as of course disability. The World Health Organization has defined certain things. For example, osteopenia. They said low bone mass, bone mineral density is more than one standard density below young normal mean, and less than 2.5 standard density and below young normal mean. Measurement of bone mass, as I said, repeat again, conventional single photon, dual X-ray absorptiometry, quantitative CT, quantitative use. And because today we are able to diagnose osteopenia or osteoporosis, particularly in the axial skeleton, with compression of the vertebral bodies, it is easy. Vertebroplasty is being done in order to maintain the strength of the bone. Inject some sort of a cement into the body of the vertebra, thus increase the size of the body of the vertebra. What are various causes? Endocrinal, Cushing, Turner syndrome, diabetes, hyperparathyroidism, hypopituitarism, hypothyroidism, hypogonadism, and besides senile osteoporosis, postmenopausal osteoporosis, etc. Again, WHO, World Health Organization, has graded osteoporosis into normal, osteopenia, osteoporosis a degree more, and severe osteoporosis. Osteopenia, as I said already, is generalized diminished bone density, such as you see even in conventional radiographs. Osteoporosis is due to inadequate osteoid synthesis. Often our students get confused with osteomalacia and osteoporosis. Easy to remember. Osteoporosis is due to deficiency of the protein, whereas osteomalacia is due to deficiency of the M mineral. And then again, to include some of the other entities, senility, dietary deficiency, endocrine abnormalities, already we have counted, disuse atrophy or stress deficiency, hypoxia, idiopathic, sometimes probably it is genetic, we don't know, racial, we don't know, but idiopathic osteoporosis is also seen. And iatrogenic, the drugs, particularly steroids, etc., and congenital. This is a classic example of a radiograph of the hand showing osteoporosis. First of all, there is diminished density with marked lucency of the bones. And also note, white cortical lines. Look at the cortex, as if you have drawn with a white pencil a line. And then trabecular resorption in the spongiosal bone. So the major finding is the marked differentiation between the spongiosa and the cortex. The cortex is thinned but not absorbed. Cortex is thinned, whereas the spongiosa bone, sometimes you see the exaggeration of the trabeculae early on. Eventually, there is no spongiosa, completely resolved. Phantom bone, they call it. Again, a cone view of the left hip in a 60-year-old male came with a fracture. While he was stepping down the stairs and just fell, and there is a fracture. This is a pathological fracture. It is not just traumatic fracture. What is the pathology? It could be just osteoporosis or sometimes plasmacytoma or myeloma. Unless you take the investigations of the rest of the body, you cannot really come to the diagnosis. But the point is, here osteoporosis, note the trabecular pattern. Look at the nice cortex in white line. And then of course pathological fracture with disruption of the trabecula. And in the spine, when there is complete collapse, complete wedging of the body, you can see vertebra plana, almost like a wafer type of vertebra. Because this patient particularly due to corticosteroid therapy. Now, I was referring to osteomalacia, the confusion between osteoporosis and osteomalacia in the young radiologist. Osteomalacia, you can get generalized lucency as you get in osteoporosis. Occasionally in osteomalacia, what happens? There is increased density explained by the excessive osteoid, as though to compensate for the proteinaceous matrix. Ground glass appearance, the trabeculae, the differentiation between the cortex and the spongiosa are gone. The cortex merges with the density of the spongiosa. Osteoid seams, so-called loser zones or stress fractures, where even a pulsatile artery can produce a loser zone. Then, of course, naturally the bones are malachic, soft, that's why deformities, particularly in the pelvis and other bones, can occur. And lack of differentiation of cortex and spongiosa, as I said already. Endosteal and periosteal newborn, occasionally you will see, there is probably due to stress. Paraarticular calcifications, fractures, and eventually osteomalacia leads to secondary hyperparathy. Again, osteomalacia, lack of differentiation of the cortex and spongiosa. I am pumping this point in the youngsters because that is most important. Endosteal and periosteal newborn. That doesn't mean there is a osteomyelitis or a real fracture. Real fractures can also occur with minor trauma, secondary hyperparathyroidism. Radiograph of the pelvis in a female, and what you find, there is increased density of the bones. Not, of course, increased density of the bones can be due to radiographic technique also. If you underexpose, bones density is increased. Overexpose, bone density, that you have to keep in mind. Apart from that, you look at the deformity of the pelvis, the pubic bones and old fractures are healed. And if you look into the femoral shafts, both on the right and left, there are loser zones. And they are attempting to heal up spontaneously. That's why there is increased density. And trabecular pattern is exaggerated. This is a typical picture of osteomalacia. And I was telling you about the loser zones. Look at the scapula. There is a transverse lucency. This is unusual for a traumatic fracture to occur. So how did it occur? It is what is called the loser zone, because osteoid seams are there, not mineralized. Even a transscapular artery with those pulsations can prevent mineralization of that portion of the bone. That's why you get the loser zone. Again, examples of multiple loser zones. And then there is what is called renal osteodystrophy. Chronic renal disease is not uncommon. And in that, you get both osteomalacia and pseudo fractures. Again, look at the bones of the foot. There is increased density. See, the syndrome, renal osteodystrophy is a syndrome. You can get osteoporosis, osteomalacia, hyperparathyroidism, soft tissue calcifications, and osteosclerosis. All these 5 combined together, we call it renal osteodystrophy. dystrophy. Any of them can predominate. For example, here you don't see much of subperiosteal resorption of bone, but what you see is increased density and osteomyelitic changes because of the looser zones. How do you estimate osteoporosis? In order to diagnose and for prognosis after therapy, we have to estimate osteoporosis. Again, to repeat the same methods that we can use. But dual energy X-ray absorption, DXA, is popular. And quantification by ultrasound is also done. Differential reflections and attenuations by broadband ultrasound, sending BUA pulse through the bone and measuring the reduction of intensity at different frequencies. Calcanium takes more than a minute to perform. People think now all consumption of time, but just a minute. Preferably calcanium, and you can do quantitative ultrasonography. Now again, coming back to the other advanced imaging modality which is so popular today, that is computerized axial tomography, in short CT. Particularly in articular disorders and rheumatology, cross-sectional views you can get. Ligaments, tendons and muscular changes you can get with good resolution. Early erosions, as we said, early erosions can be done by ultrasonography, but in CT also, but earlier you can get in ultrasound than in CT. Early calcifications, which you cannot really tell by ultrasonography, all you can tell is it is echogenic. It's the fat, calcium, bone, can't really differentiate. Whereas in by CT, although the plain films may not show any calcium, CT is so sensitive, it shows early calcium. And of course, identification of vessels and nerves. Cross-sectional images can't, with high contrast resolution, CT 0.25%, whereas radiographs 5%. See the high sensitivity. They used to call earlier CAT scan, which in 1972, that was the first time the CT scan was invented by Houndsfield, got a Nobel Prize later. And look at the sacrum and looking like a smiling rabbit or something, and it's a cat. Sir Godfrey Houndsfield and Alan Cormack, these are the people who have got Nobel Prizes. Role of CT, what is the role? Look at the cross-section of the apple. We always say, when you see an apple, it looks so nice. Unless you take a cross-section, you don't know how many germs are there, how many seeds are there, how many rotten things are there. So, the CT also gives us the cross-section of the bones, cross-section of the structures, cross-section of the brain. From head to foot, you can do CT. For anatomical localization, cross-sectional image, as we said already, detection of calcification, tissue differentiation. Is it fat? Is it muscle? Is it tendon? Is it bone? Is it cut? That tissue differentiation can be done by CT. Outline soft tissue component, reconstructional images. You can reconstruct various planes, cross-sectional, coronal, sagittal, etc. These are the Houndsfield units. Earlier, you remember in ultrasound we were telling about echoes, echogenic, hyper-echogenic, non-echogenic, echo-less, and hypoechogenic. Here we use Houndsfield unit, in terms of, for example, 3000 is bone and minus 1000 is fat and air, for example. Lung minus, because mammary gland it contains fat, is minus, whereas spleen, pancreas, water as 0 is taken as this. So you measure the densities in CT by Houndsfield unit. If it is, say, 2500, bone immediately is minus 200 or 400, then you can think of fat or